So imagine you're in the critical care area of your ER and you get told, hey, I have a lady for the last few days been having shortness of breath, confirmed with hypoxia recorded in the 80s on pulse ox, on room air, syncopizing, EKG just shows intermittent showing sinus tachycardia, but no ischemic changes, a troponin that's positive, a pro-BNP that's positive, and a bedside echo that shows RV strain. What do you do then? CAT scan's a little busy with traumas, but this patient's sick too. Can you treat for a PE without the proof of a PE? Well, it haunts you that you defer starting heparin that prevents the clot from getting bigger and lets the body to reabsorb all clots. Because right now I have clots in my lung that are reabsorbing constantly, but they're forming and lysing constantly. The issue is something caused her to be procoagulable. Not COVID. She didn't have sick sepsis-induced coagulopathy. She isn't bedbound, but she's older. Maybe she has an occult malignancy. She's not on OCPs or hormonal therapy, but what do you do? CAT scan's busy. I'm going to tell you straight up. In my opinion, you could give TPA now, if you have RV strain, but then it'll be a submassive PE, not hypotensive. If anytime she's shocky and drops the BP and you keep bolusing a little bit of amount of fluid, 250, 500 cc's at a time, and BP gets up, you're staving off the inevitable. She's about to code eventually if you do not give her lysis. Now, the lysis can either be cat-directed to the clot, if systemic anticoagulation and thrombolytics is deemed too dangerous. Usually you do a CAT scan of the head to make sure there's no goomba, no badness in the brain before we start the heparin or the anticoagulant. So TTA gets ordered. You can actually start the heparin or get the TPA primed. Now, if you document there's no neurological deficits, no trauma to the head, and she gets shocky, give the thrombolytics over 2 hours. It gets more baller to do the thrombolytics before the CAT scan's done. No one will fault you if she gets shocky, gets episodes of hypotension, and gets more distress. More scary is waiting over 2 hours of the infusion instead of giving it over 10 minutes, 50 milligrams or 100 milligrams. One thing, if you give heparin drip, Lovenox, who cares? She gets shocky, you stop that stuff, the drip. You already gave the Lovenox, just commit to the TPA giving it. If you gave the TPA over 2 hours or with a bolus, you have to check the INR before you're starting heparin because maybe got super anticoagulated. Maybe too much and you may promote excessive anticoagulation and cause bleed. Make sense? Get your contraindications ready. Do the checklist, pros and cons, and discuss it with the patient. If they get lethargic, unresponsive, try your best not to intubate these patients. You will kill them. You'll drop the blood pressure on the right, and now it has RV strain and failure, and you will cause death. And you may fight it off with pressors, but that's not what's going to improve this patient's life. The lytics or removal of thrombectomy. Good luck on that. Good luck on that. So be baller. If you know it's likely to have a PE, well score is 99% to 100% likely, and the facts show a PE. If you wait for the CT angio, it may be too late. You got to decide, am I going to go submassive, forced admission into the ICU, give bolus of lytics right now, or give heparin? Heparin's an okay answer, not a baller answer. It's the PG, it's the G rating on Disney movies answer. The awesome answer, the Oscar, is likely lytics if she gets sick. Don't wait for ICU daddy or mommy to tell you how sick the patient is and say, nah, we don't want lytics. Force it. We give lytics like water for strokes or things that are pseudo strokes or questionable strokes. Why can't we give it for something that's definite? Definitely a PE. And confirmed eventually. Make sense? RV larger than left. D sign, right ventricle crushing the left ventricle. D. Right ventricle as large as the left. Right, left. Okay, right ventricle as large as left. Positive troponin, positive pro-BNP, positive CT scan. Submassive PE. Got 2 hours worth of TPA, 100 milligrams. Admitted to the ICU.
Beds out to get them out of there ASAP because we definitely
Extensive PE.
I hope so because we have beds on MICU.
Syncope, shortness of
Can I
breath.
ask you to help me to get a bed on that side if we cannot create bed on this side?
Where are the
Because
clots?
right now we have an intubated patient that definitely needs to come up.
Here.
And we,
Not a saddle.
and we have another patient who has
Clot
gunshot
here.
wound to the leg with vascular injury. She's going to go to the OR
Clot
and
here.
to come to CQ post-op.
Clot.
So we need at least 2 beds right now.
If you look carefully,
I mean, one definite,
right
but
artery,
not one
right
possible.
ventricle, larger
Let
than
me
left.
tell you the definite.
The lady with
Just
the
one.
lower extremity injury, can
I
you
thought
look
we
at
just
her
have
blood
7,
pressure?
right?
She's feeling dizzy. She's 90s over 60.
One on each side. Okay, let me tell you the guy that
Her
needs
map
to
looks
come up.
good, but,
His
you
name
know,
is Hicks,
bleeding.
Hicks.